welcome to today's podcast. My name is Ghita Szafranska. I am one of the speech and language pathologists here at Cleveland Clinic, Abu Dhabi. And today we will share with you some insights into the broad and impactful work that happens every day within speech and language therapy department here at Cleveland Clinic, Abu Dhabi. We will also discuss some of the vital roles we play in managing various health conditions in the acute hospital and outpatient settings. Today, I am joined by my very own colleagues and highly specialist speech and language pathologists, Fatema Nasser and Priyanka Jain. So first off, Fatema, tell us a little bit about yourself and your background.
Well, firstly, thank you for having me here today for the podcast. My name is Fatema and I'm a British-trained speech and language therapist. I graduated in 2010 from University College London and joined Cleveland Clinic Abu Dhabi in 2019. My work history has predominantly been working within acute care hospital settings and adult population group.
Excellent. And Priyanka, tell us a little bit about your background and introduce yourself.
Thanks, Rita. Thanks for having us here. My name is Priyanka Jain. I am a medical speech language pathologist. I graduated from Bowling Green State University in Ohio, in America, in 2011, and I've worked as a medical speech pathologist for over 12 years now. I joined Cleveland Clinic in 2021, and my primary focus has been head and neck cancers and stroke.
Great. So I feel that when people think of speech and language pathology, they often picture children working on articulation or language disorders. But in reality, our role extends far beyond that, from addressing communication impairments as a result of strokes, brain injuries, neurological conditions, to treating complex swallowing disorders. Our work appears to be a vital component to managing various health conditions and providing critical patient care to their recovery. So Fatema, a large bulk of your work has been in critical care. Could you talk us through the role of the speech and language pathologist working with this cohort of patients? What sort of cases would you come across typically?
Of course. So speech and language pathology play a crucial part in critical care and ICU settings, where we have the most vulnerable population group here with complex medical conditions that can affect their speech, their swallowing, and their communication. Here at Cleveland Clinic Abu Dhabi, our ICU treats complex medical patients post-surgery, such as heart transplants, heart surgery, patients with complex respiratory failure, illnesses such as chronic obstructive pulmonary disease, or a severe case of a viral infection, such as COVID-19 or influenza. All of these conditions can result in a patient becoming mechanically ventilated. And these sort of population groups tend to have significant impact and difficulties with their swallowing and their communication, because these muscle groups that we use for talking, for swallowing, can all be impacted and affected quite significantly. Someone who has been mechanically ventilated may also have a tracheostomy, which is an artificial airway that is put through the neck, an opening in the neck down to the trachea, and allows a patent airway to be given and assist with removal of secretions. Often patients in the ICU who have a tracheostomy or a feeding tube that goes through the nose or directly to the stomach are referred to speech therapy to identify a safe method of feeding. So naturally, normally, healthy adults, we eat and drink and allows the safe passage of food from the mouth through to the pharynx, which is the back of the throat, and into the esophagus. However, the patients in the ICU setting are at much increased risk of aspiration due to prolonged mechanical ventilation, tracheostomy, or even high-flow oxygen needs, where rather than the food and liquid going to the stomach, it actually ends up unsafely into the lungs, and as you would expect, can cause significant life-threatening respiratory complications. So where signs of aspiration, such as coughing, choking, gasping, would help us understand that something is going the wrong way, in ICU settings and these kind of patient population groups, unfortunately, sometimes these signs are not visible. They can be what we call silent and can give us the misunderstanding at bedside when we give someone water or food that they're doing okay and they can eat. And this is where speech therapy played an invaluable role within the multidisciplinary team to assist with understanding, can these people safely eat and drink, and how we assess them to make sure that we're not allowing someone to develop an aspiration pneumonia and respiratory complications.
Excellent. So you mentioned instrumental assessments. So could you talk us through the different types of instrumental procedures that are available here at Cleveland Clinic Abu Dhabi and tell us the difference between them?
Yes, great. So we talked about identifying swallowing difficulties at bedside, and in the case where we don't have those visible signs such as coughing and choking and gasping, silent aspiration can be quite challenging, even for a speech and language pathologist, to identify if it's happening. So we use instrumental assessments, and these are specialized tools that a clinically trained speech and language therapist can use to identify if there is any evidence of silent aspiration. These equipment help us determine that and guide treatment plans, intervention, and progressing someone onto eating and drinking and returning to that enjoyable activity. Here at Cleveland Clinic Abu Dhabi, our speech and language pathology team use two different types of instrumental assessments. The first one being a video fluoroscopy swallow study, also known as a modified barium swallow study, or a fiber optic endoscopic evaluation of swallowing, often abbreviated to a FEES assessment. Both these assessments allow us to directly visualize objectively where the food and drink is going, takes away a little bit of the guesswork or subjective component to determine when the swallow is triggered, where the food is going, and if anything is going the wrong way through the larynx, down to the trachea, and then into the lungs. So a video fluoroscopy swallow study is an X-ray swallow procedure where a patient is given food or drinks mixed with barium, a contrast that shows up on X-ray, and we watch the food and drink go through the entire oral swallowing mechanism. So starting at the mouth, going through to the pharynx, and then into the upper esophagus. This has many benefits because it allows a direct visualization. We can see more than just what's happening in the throat and can allow us to guide what happens next. However, there can be some limitations with this study in that a patient does need to be transported to the radiology department to do this procedure. And sometimes in our ICU settings or critically complex patients, it's hard to transport them. They've got lines, drains, airways that can make optimal upright positioning quite challenging. And this is where we may choose another instrumental assessment. And this would be our FEES assessment, which is really a small, flexible nasoendoscope with a camera at the end. We pass it through the nose and into the pharynx, and we can watch the structures at rest and during swallowing. We also are able to see the voice box or the larynx. We can see how the vocal folds move, whether they come together. Often after intubation, we can have some short-term intubation trauma to the voice box, which is where we liaise with our ear, nose, and throat doctors to help us identify if there's anything else there that they can assist to manage, which can impact the swallowing. We give food and drinks, and we observe where they go. So the benefits of this is that it can be brought to bedside. So it's not so challenging if we've got patients who are immobile, cannot be transported. It's an easier assessment and safer to do at bedside, particularly with our patients who may, for example, be connected to ECMO, where it is very challenging and lots of precautions need to be taken if they're going to be transported off the floor. It's also a benefit in that it doesn't have any X-ray radiation exposure. So where someone needs to be repeatedly go through this procedure over a period of time to show improvement and check progress, a video fluoroscopy swallow study does have a radiation exposure component that needs to be monitored and carefully considered. So a FEES assessment could be something that can be repeated without that concern. Mm-hmm. A limitation of the FEES assessment may also be that it does require someone to tolerate having a nasoendoscopy passed through the nose, which for some can be a challenge.
Thank you so much. That's very enlightening. So coming to you, Priyanka, you have a strong interest in the area of head and neck cancer. Could you talk us through the role of the speech and language pathologist working in this population, and what sort of cases would you come across potentially?
Thank you, Rita, for asking that question. We at Cleveland Clinic Abu Dhabi, we do have weekly tumor board meetings where patients with head and neck cancer, they get discussed. And we are also part of the tumor board meetings. We do get consults if they are clinically necessary. And throughout the journey of patients with head and neck cancer, we focus on three things. First being preventative. What that means is we give them the education. We focus on establishing a baseline, and this is pre-surgical, pre-radiation therapy. We also work on maintenance. So while they are going through their treatment, of radiation or chemotherapy, we do see them follow-ups at regular intervals. And then we also focus on the third aspect is rehabilitative. What that means is after surgical or chemoradiation has been completed, we see them for rehabilitation, working on those muscles that could have been impacted because of a intervention or a combination of interventions. So just kind of to go back on the preventative part, what we do focus on is first establishing a baseline. What that means is we do clinical assessments, and then we also follow up with video fluoroscopy, as Fatema mentioned, because that gives us very objective information as to how their oral and pharyngeal phase is functioning at the moment while having the burden of tumor. So we need to know what sorts of solids are they eating, what sorts of liquids are they eating. And then a part of the burden goes on education. So we make sure that we give exercises to our patients in advance to make sure that they are practicing it and keeping their function closer to the normal, even while they are going to go through the treatment. I think the most important thing we focus on is use it or lose it. So if they don't use it, there's a high chance that the muscles will get deconditioned or the impairment severity might be increased in the later stage. And the focus is more on like improving the quality of life and having that aspect in mind that we want patients to eat and drink whatever they loved even before the intervention or the cancer had come in. Now, for the maintenance bit, what we do is bi-weekly follow-ups, and in that we don't do any kind of instrumental assessments. We basically do clinical assessments, troubleshoot any difficulties that the patient might be experiencing, and also reiterate the education, make sure that they're following the routine, and we call it as pharyngosize. And in the rehabilitative part, what that means is after the surgical or chemoradiation has been completed, with the clearance of the ENT physician and also the medical team, we start introducing some gentle range of motion exercises. Because a lot of the time there has been some swelling. So we would start with like tongue exercises, jaw exercises, because of the range of motion that can be impacted. And what that means is actually the mouth cannot open quite a bit. So we want the spoon with the food to go inside the mouth so that the patient can take the food inside. So we start with the exercises in a gradual manner as per the clearance, and then we start with a very intensive rehabilitation program 3 months post radiation, because there are some risks of side effects, having fibrosis, having stiffness in the muscles, having sensation reduced. We also want to make sure that we emphasize on the oral care aspect, because a lot of the times there's dry mouth, and then we want to make sure that the oral hygiene is great, because even there's a risk of pneumonia that can happen if the mouth is not properly cleaned. So as a speech pathologist in the acute care setting, and even we have follow-ups in the outpatient clinic, we follow these patients pre and up to the 5 years post cancer identification. And some of the cases that we see is like glossectomy. What that means is part of the tongue has been removed where the tumor was, and then it's difficult for them to manage the solids. How are they going to chew? It's difficult for them to control their liquids. The liquids enter into their airway or into the pharynx prematurely before they are even ready to swallow. So to have that training, and then also like someone with a special consideration of laryngectomy, where the whole voice box or the larynx had been removed, and there's a stoma, so just make sure before they get discharged, when they are starting on an oral diet, there is no leakage from the stoma. Someone with a pharyngeal cancer, there's a higher risk of the liquids and the solids going down into the airway. So we use compensatory strategies, and obviously we do an instrumental assessment, preferably video fluoroscopy, to identify what's the safest diet and how can we wean them off of the NG tube, which is a nasogastric tube, and increase their dependency and efficiency, independence and efficiency of swallowing, so they can return to a full oral diet. And it's all a collaborative, multidisciplinary approach with the dietetics, medical team, ENT, respiratory therapist, and so on.
Excellent. And Priyanka, in terms of communication impairments, what sort of conditions would you come across and how do you typically manage them within this cohort of patients?
Sure. So while we are also focusing on swallowing, we also focus on the communication aspect. So in the preventative session when they're coming in, we do introduce some low-tech alternative augmentative communication suggestions, make sure after the surgery, they won't be able to articulate or speak. So they need to make sure they have a writing pad, pen, simple picture boards, alphabet boards ready with them. So whatever they want to relate to the nursing staff, to the family members, they have that immediate way of communicating. During their hospital stay, depending on where the tumor was, so if it was somewhere it was obstructing their airway, and they do undergo tracheostomy, Fatima mentioned, that it's an artificial airway going through the throat. So in those cases, we collaborate with the respiratory therapist and the ENTs, get clearance, and we can use speaking valve, which can be placed on top of the tracheostomy to make sure that they can speak and they can coordinate their breathing and speech. So that can remove that frustration and the negative emotions that can come in when we are not able to speak. And then someone with laryngectomy, we could have a TE prosthesis, which is a tracheoesophageal prosthesis, and to have them practice with how they can speak while having that valve in and how to take care of it. So that's the education bit that we go through. And in some cases, we also have something called as electrolarynx, which is basically a device. We have them placed around, at a suitable position in the on the throat, and that vibrates, and they can use that vibration and articulate. So there are different avenues that we can use. And one of the most common ones that we use is like someone with oral cancer, where part of the tongue was removed. Obviously, they are not able to articulate their sounds. So we work a lot on compensatory speech strategies like stress your sounds, go slow, speak loudly. And we also work closely with the family members or caregivers to make sure that they give them plenty of time to talk, as well as reduce the background noises and environmental modifications. So it's not just the patient, but also managing the family and the team around to make sure the communication always keeps happening. It's not disrupted, to make sure the patient still feels independent and ready to go back into the real world.
Excellent. Very, very interesting. So you mentioned about the multidisciplinary team and the tumor board. It seems that including speech and language pathology in these important discussions is pivotal. Could you tell us about any other multidisciplinary team meetings or things that speech pathologists would be part of in Cleveland Clinic Abu Dhabi?
Sure. We do have weekly meetings for discussing all tracheostomy patients, and it's in collaboration with the respiratory therapy team and also the ear, nose, and throat team. And we essentially talk about all the tracheostomy patients that are in-house and take a closer look at the weaning process. So also something like someone needed an artificial airway at the time of admission because of different conditions. It could be a stroke where the alertness was less, or it could be for the head and neck cancer. And then we discuss from each perspective, is this patient suitable for further weaning? And by weaning, essentially, I mean can they be a candidate in future for the removal of the tracheostomy tube, because we want them to return back to their normal way of breathing. And it's a wonderful team approach, because we have so many patients that we do have successful decannulations over here. And if in case they need further follow-ups, then we do make those referrals out to the clinics. We do have other kinds of multidisciplinary team meetings for different patient populations, which I would like Fatima to shine light on and discuss more.
Of course. So there are many other multidisciplinary team meetings that the speech and language pathology team attends regularly, particularly for our neuro or our stroke patient population group, and we attend them at various different parts of their rehabilitation journey. So that would be inclusive of our ICU setting, the acute care unit, and also outpatient settings, where we collaborate with the doctors, the nurses, occupational therapists, physical therapists, case managers, social workers, where we align patient-centered goals and we discuss any challenges or barriers to discharge, return to their normal activities of daily living. And speech therapy is very important in this. Specialized evidence-based targeted therapy can actually allow a patient to return out back to their normal living sooner. So we can reduce the length of stay, we can help in assisting reduce use of resources and facilitate that, particularly for those that may have things like an artificial airway, the tracheostomy, or we talked about enteral feeding tubes such as the nasogastric tube. Those can be a real challenge and barrier to allow safe discharge into the community because they require medical care, nursing care to support them. It can also be a barrier to get onto a flight and be repatriated to your home country. So by allowing those tubes to come out, it can actually allow a patient to return home to their home environment internationally much sooner.
Thank you so much. Thank you so much for joining us today and for sharing your invaluable expertise. It's been an enlightening discussion that has truly shed more light on the diverse roles speech pathologists play in acute care settings and beyond. There's no doubt we could spend hours covering the full scope of what SLPs do, but today's focus on critical care and head and neck cancer has given us a profound understanding of how essential this work is in supporting patients' communication, swallowing, and overall quality of life. For those listening, we hope this conversation has been as informative and inspiring for you as it has been for us. Thank you for tuning in, and we look forward to having you join us next time as we continue exploring the vital work of speech and language pathologists across different clinical settings.